Insofar as the value of research findings or conclusions rest on the quality of the research process, and while quality is fiendishly difficult to measure, should we have concerns about the quality of nursing qualitative research? More specifically, should we be concerned about the way in which nursing qualitative researchers are educated and encultured? Hello, my name is Martin Lipscomb, and I'm talking to Associate Professor Shira Birnbaum of Rutgers School of Nursing, New Jersey, America. Shira recently authored an interesting and provocative commentary which appeared in the journal Nursing Inquiry, titled "It Takes Time to Develop Interpretive Depth in Qualitative Research." And so, without overly long introduction, Shira, thank you for joining me, and please, would you outline your ideas? What concerns do you have about the quality of nursing qualitative research and qualitative research education?
Thanks for having me. I will just get right into it. The piece was brief, as you note, it was an editorial, but I'll go a little beyond it in my description here. The point I made starts with the fact that many concerns are now being expressed about quality in qualitative nursing research. Anyone who reads journal submissions will tell you we have a problem. And much of the concern focuses on the problem of proceduralism, a tendency to treat qualitative inquiry as a matter of following a set of steps, executing procedures with too little regard for producing new, meaningful insights. Right? Some of the work is very shallow, presenting lists of something called findings, but lacking any kind of substantive interpretation. Sally Thorne is one example. I think you've had her in this series. She's talked about thematic analysis, the proliferation of thematic analysis. That so many nurses are now engaging in elaborate mechanical rituals of sorting and labeling. It's quite superficial. Other critics have talked about methodolatry, right? The fixation on technique, on methods that treats qualitative research as something like a how-to manual for conducting interviews and focus groups. You've had Joan Eakin in this series. She's a medical sociologist looking at the whole of qualitative health research. She's gone so far as to question whether it's even making useful impact because it's become so procedurally focused. Following literal checklists of, papers have a sciencey veneer, but really are not contributing substantive insights. So the question that I address in the commentary is why? Why is this such a tenacious and persistent feature of our work? So there are a few interconnected answers. The first one being that a lack of broad exposure to the world of scholarship simply keeps people in a naive state. You've written about this. You've observed that many nurses don't learn enough about social theory, sociological theories. So they have difficulty situating their work in reference to the broader world of ideas, to the broader world of scholarship. I think that's true. And what I say in the paper is that any educational psychologist will tell you that novice learners always initially assimilate new concepts into pre-existing schematic repertoires. When people are in the beginning stages of learning something new, of course they try to make sense of it by fitting it into their pre-established structures of awareness. You don't know what you don't know, as the saying goes, so you're not aware at the outset that your structures of consciousness may be limited and insufficient. Nobody emerges from the womb being able to name all the drinks at the bar or all the animals at the zoo or the ways that humans mistreat one another or behave scandalously. You first attend the school of hard knocks, and you practice alerts you that there's stuff out there you didn't know was a thing. Experience challenges the mind toward conceptual elaboration. This is just a principle of learning. And it's not any experience, by the way. It's experiences of discomfort, lingering discomfort, staying in the space of cognitive dissonance and curiosity about that dissonance that actually functions as the propulsive force, the generative force in conceptual development. That's what we call learning, and it takes time. So it's not surprising that nurses would encounter complex research craft knowledge from the social sciences and humanities and try to absorb it into the more familiar schematic framework of applying correct technique. Procedures matter enormously in clinical work. Having a list of steps, executing them absolutely correctly and precisely can spell the difference between life and death in the work that we do. And technique is a source of pride for us. We admire coworkers who are, really adept at carrying out particular clinical procedures. So it's not unpredictable that clinicians would default to assuming that's just what there is, right? You execute well and scholarship happens. The lack of exposure of lingering in the dissonance space, right, goes to the heart of even knowing what kinds of questions qualitative research can answer. If you've never read a sociology monograph, an ethnography, a historical analysis, a book in phenomenological psychology, you'd have no experience in how scholarly argumentation is structured inductively. If all you've seen are studies in a deductive framework that use, theories to develop a hypothesis and gather data to test the hypothesis, you may not have any idea that there are other things research can do, other things that scholarship can be designed to accomplish. There's no reason that you would know. Even more difficult is the issue of the nature of facts and knowledge. We spend most of our professional lives gathering data which are external, right? That are sitting out there waiting for someone to discover them, measure them, elicit them, like objects handed over, from research participants in a survey. We take blood pressure, temperature, weight, blood gas, whatever it is. We have to assume these data exist in an ontologically stable sense because you can't do healthcare without that. So of course nurses would assume that doing qualitative research, initially they would assume, is kind of like that. It's you like collecting blood pressure readings, except it's interview transcripts. There's no reason to conceive of anything else until you're challenged to do so. If you do a survey and you gather perceptions of X, Y, and Z, right, somebody has to come along and say, wait a minute, that's not a perception. It's a discursive strategy, right? It's a social construction of identity. It's a narrative of self rendered meaningful by such and such, contextual needs. Or that's a complicated challenge. And you don't grasp that kind of thing from an instructional manual. Our students quite often arrive with very little previous experience of long-form argumentation. Their education has been mostly textbook based. It's focused on skills development, which it needs to be. That's how you learn to save lives. But they come in, absolutely sure that qualitative inquiry generates low quality evidence. That's how they've been indoctrinated. They've been taught to dismiss, the entire discipline of history, maybe without reading a history book, right? The entire corpus of anthropology, tens of thousands of scholarly works in sociology and political theory, without necessarily knowing how arguments are put together in those fields and why and what purposes they serve. A big part of the problem, as you've written and as we've discussed a little bit before, is the impact of the evidence-based practice movement in nursing. And Sally Thorne has written extensively on this, as have you. I'm not knocking evidence-based practice. Making treatment decisions based on facts, based on evidence, is much better than making treatment decisions not based on facts and evidence, right? We need evidence-based practice, but many people in EBP have not grasped that there's a distinction between scholarship designed to generate empirical evidence for hypothesis testing to evaluate treatment impacts, and scholarship that's designed for a different purpose, scholarship that's designed to foster new perspectives for thinking. And again, it's just lack of exposure to different forms of reasoning. Which brings me to the second aspect of why there's so much proceduralism in qualitative nursing research. And that is that we do it on purpose. There's an acute shortage of nursing faculty now, particularly in the United States, where aging professors like me are retiring. You can see my gray hair. And there's very little funding for graduate study. So many nursing schools have responded by building shorter, easier pathways to the doctorate. We've condensed program timelines. We've created abbreviated part-time, options. We've become very financially dependent on revenues from various clinical doctorates and novel, postgraduate certification programs that are good in themselves, but aren't designed to provide what's normally regarded as scholarly rigor. We've got committees staffed by people who hardly done any qualitative research beyond basic description. So we in a sense, literally dismantling the pedagogical infrastructure of qualitative inquiry, the venues that foster what I just a moment ago called conceptual elaboration, where students have time to read and to explore and have their existing assumptions challenged, where they can experience the moments of discomfort, those transition periods that really foster growth. Why is this bad? It's not bad because it means we're doing qualitative research wrong. It's bad because it's an egregious waste of us, of our potential. Nobody is as much an insider to the care process, to the organization of care as nurses. Nobody achieves the intimacy that we achieve with patients, with lived experience of illness, with the lived experience of care. That gives us such tremendous capacity to contribute to the study of health and the study of illness. We have so much to offer. That should be nurtured and fostered and developed to its potential, not truncated and reduced. If I were in any other profession, a lawyer, a pilot, an accountant, a plumber, and I wanted to learn how to do nursing, I could go over to the nearest elder home and shadow the nurse. I could start in the morning and keep a detailed list of all the steps she takes, right? She takes reports, she checks the meds, she notes the orders, she assembles the supplies, all of that. And by the end of the day, I could say, look, I've got a list. Here it is. This is how you do nursing. I've got this. As nurses, we understand immediately that this is ridiculous. It reflects a complete lack of understanding of what nursing is. But that's exactly what we are increasingly doing with qualitative inquiry. We've deracinated it because it makes it feel like you don't need a lot of time to teach it, right? You offer a course, maybe less, maybe a workshop, and you have students purchase the textbook, and that's it, done. They know the steps. So that's what the paper was about. I got many comments about it. I got emails from all over the world. I'm clearly not alone in feeling that we're in a bit of a crisis. It seems that many people are quite concerned about this. So that's it.
Shira, that's really interesting. Thank you. I very much recommend that any nurse who's interested in qualitative study should read your piece. Although short, it contains much to think about. It generates lots of questions. And so let me ask you, you say that, to quote, many in the evidence-based practice movement have not grasped the difference between studies that offer new perspectives for thinking and studies that generate empirical data for hypothesis testing, end of quote. But first, you've spoken to this a little bit. I wholeheartedly agree. In conversation with students and occasionally staff, I'm struck by the, to me, odd way in which qualitative conclusions are assumed to be action guiding in the same way that sometimes quantitative results can be. And although my formulation of the problem differs a little bit from yours, please, why are qualitative generated conclusions or ideas so easily misconstrued? You've approached this a little bit, you've talked about this a little bit. Why do you think new perspectives for thinking are frequently reduced to data suitable for hypothesis testing? And I suppose the million-dollar question, what can we do about it?
When you learn about scholarship in nursing, usually, you learn that you're supposed to use representative sampling to test theory-driven hypotheses, to
Mm.
discover generalizable laws, to add to the facts that people know, measuring the impact of an intervention, comparing treatment options, right? Your goal is to add pieces of knowledge. This quantitative positivist approach for the last few hundred years has been the basis for the most important discoveries of modern science. There's good reason to want to embrace that and promote that. But we have, again, an exposure problem in nursing. Our students are not getting to see that there are other ways that scholarship can also work. Approaches from the social sciences can also be valuable, but we need to help students understand that they don't work exclusively by adding more facts to the body of knowledge, more evidence about the efficacy of treatment. Can't necessarily squeeze them into an evidence table like we tell students to do all the time. They work by seeing how existing ways of looking at problems can be shaken up. It's almost like trying on a new pair of eyeglasses. That's what qualitative inquiry really is about. It's to check if different lenses will render visible different elements, different issues, different concerns. If you call up from the background of experience a different configuration of things, can you name something that may be usefully addressed? Can it trigger creative problem solving? My students are always shocked when I tell them, I'm not here to find truth. But that doesn't mean I'm seeking untruth, or it doesn't mean I'm just making a gathering collection of opinions. It means that instead of trying to add new facts to all the other evidence, generated about interventions, I'm proposing a different way to consider the situation as a whole. And my conversation is directed not at something that'll last to eternity. I'm not seeking to pinpoint an eternal truth. I'm introducing a new perspective into the community of scholars, into the community of scholarship, where my argument is going to be judged not on the procedures that I use to get there, but on the insights that it has the capacity to generate. It's a different logic of inquiry. And I think in some ways that's what we are missing pedagogically. That's what we need to kind of stress to our students. We need time to do that. I think you captured this quite well. I really like your 2020 book, Nursing Literature Reviews. You give the example of someone you call Jane, right? She's some imaginary researcher that you created to illustrate your point. And she's so concerned with doing the correct steps in a systematic review, narrowing the search parameters, listing the search terms, ruling out information that doesn't meet certain numerical criteria, right? Which is what nurses are told is the right way, the science way to search literature. And she ends up with material that's so narrow, I think you call it pinched, which is such a great description. So she's so lacking in a comprehensive awareness of the body of work on the subject. Her findings seem uninformed and naive, as if she doesn't even recognize that there are different kinds of questions that could have been asked. Her highly wrought and decontextualized form of searching, it looks like science, but it makes it virtually impossible for her to learn something she didn't know ahead of time. And the result is, I'm sorry.
No, I was going to say, since you're agreeing with me, I fully agree with you. And yet the problem seems to me, the rubber hits the road at the point. Nurses need to act in the world, and the type of idea, knowledge, however we want to describe it, that good qualitative research throws up, it doesn't tell us how to act. It gives us new ways of thinking. I think that's where there's a tension or a problem, in my view. What do you think?
I agree 100%, 100% with that. I mean, we as a discipline, as a profession, we are solution focused, right? That's a source of pride for us, right? We're going to come into a difficult situation and we're going to fix it, right? We're going to save somebody's life, right, in a crisis. And that's, we need that. But sometimes we need to stop and take a breath and say, I'm not going to solve this problem. In fact, I'm just going to think about the problem. I'm not even going to think about solutions. I'm going to think about the problem itself.
I 100% agree with you. And of course, on a busy ward, that's exactly what you can't do. But
Right.
I do agree with you 100%. And it is a really, it's a tortuously complicated problem. Mm. Um, Dr. Shira Birnbaum, that was really interesting. Thank you. Links to your work and obviously the commentary discussed will be lodged in the notes. And once again, thank you for your time. It's a fascinating commentary, and I recommend everyone should have a look at it.
Thank
Thank
you
you.
very much for having me.
Thank you.